Thank you, Dr. Yang. Sorry, I make the mistake. I think it's TILIF. So the topic is thoracic ORF. So very challenging case, difficult case, but the 4D compression. Thank you again. Because severe timeout, so next, welcome next session moderator, Dr. Warren.
Muchas gracias a todos por esperar y por su atención. Thank you to Dr. Heyun Yang for sharing. And thanks to Dr. Javier Quillo Olvera, Dr. Rahaj George for bringing to us wonderful topics. And let me introduce the next person who will share with us, Dr. Wei Sang. He's a founding member of the ISUBE Association and senior consult on Endoscopy Mass International UBE, and has established the UBE China organization to publicize the development of domestic UBE and the outside the world, show the style of Chinese UBE ear, and have the certain influence on the international UBE academic community. Welcome, Dr. Sang Wen, to share his experience with us.
Today my topic is also the thoracic case. The content includes the indication, anatomy approach, portals, position, and operation, the video, conclusion. In my center, the indication of the UBE thoracic include the OF and disc herniation and OPIL. First, we will review the thoracic anatomy. We cannot make a location according to the spinal process. For the spinal process is go down. It's not in the same level with the disc space. Is different from the lumbar case. Second, we cannot choose the interlaminar approach because the disc space is not in the same level. So we can choose the keyhole. The translaminar approach is a common approach. The Dawson named the yellow-pink boundary. The yellow is superficial flap ligament. The pink is laminar. This is a start point of the translaminar approach. The yellow is superficial flap ligament. The pink is laminar. The color different under the endoscopy. OF is from the deep layer of the flap ligament. So you can see the color difference under the endoscopy. The yellow is superficial, the flap ligament. The pink is laminar. So the start point of the thoracic translaminar approach. The OF is from the deep layer of flap ligament under the laminar. This is superficial layer, and this is deep layer of the flap ligament. The transparent medical illustration shows the shape of the flap ligament, similar to the lumbar flap ligament. The left and right and up and down, the different size. The foraminal area is similar to the lumbar paraspinal approach, too much vessel and the intercostal nerve. So pay much attention to the vessel, the radicular artery, so big vessel. Summary is the UBE approach for the different disease. OF, I often choose translaminar. Soft disc herniation, I choose the paraspinal or paraspinal transpedicle. Hard disc herniation, I will choose the paraspinal or hemilaminectomy with the total fascectomy. The picture shows the angle of the different approach. The design of the position of the portals according to the area of the OIF. The pedicle is a constant structure with lateral variance. So we will according to the pedicle. For example, this case maybe the low margin of the pedicle, the up margin of the pedicle. So I design the position of the portals. But no, I change. This right line I am more lateral because the distance is too narrow. So, but for this case, I choose the median margin of the pedicle. I use the Q-valve to mark the low margin of the pedicle. And at last, this is the midline and the median margin of the pedicle. At last, I use the tip of the Q-valve to make sure the exit the portal compared with the structure. Then the root, the dilate, meet with each other together, triangle. Another new method to make sure the full decompression is the basement of the spinal process. Because the OLF is under the basement of the spinal process, so we find the up margin of the basement spinal process and low margin. So this area, we can do the full decompression. For the transpedicle portals, the blue line, the horizontal line was located in the mid pattern of the pedicle circle. And the red line is the lateral margin of the pedicle. And beyond about 1.5 centimeter, the cross point above 1.5 centimeter, below 1.5 centimeter is work portal and wheel portal. This is paraspinal portals or transforaminal portals. It's similar to the lumbar case. This video shows the matured OLEM, but we must try to protect the arachnoid member to prevent the leak of the cerebrospinal fluid. It's very thin, but I preserve it. This case, the same case. Can you help click the video? Okay, the yellow pink, the boundary. This is a left case. So the dorsal is the fat is a good friend. If you find the fat tissue, maybe this is an easy case. The fat tissue is located in the midline of the spinal canal. This is a contralateral side. So we have identify the adhesion between the OF and the dural. The thin kerosene punch, about 130 degree. I use the burn to mix in the OF produced by Bounce Company. Mixing and thin, we can use osteotomy or kerosene punch to remove the OF. The small size angle of the osteotomy is designed by me. For decompression. This case is up-migrate soft disc herniation. For this case, I choose the parasmano approach and the transpedical approach. The parasmano approach first, we can see the intercostal nerve root. This is nerve root, and this axillary area. From this area, we find the part of the disc fragment. But I think it is not enough. So I choose the second approach, is transpedical approach. This is up margin of the low margin of the pedicle. This is medial margin of pedicle. I make thin the pedicle to make thin the medial margin of the pedicle to get the last disc fragment. I use the nerve root detach to peel off the bone, the medial margin part. At last, we get the last disc fragment. Above is a spinal cord. Below is the intercostal nerve root. Another case by the transpedical approach is fracture case. You can see there is the bone to compress the spinal cord. But the bone is located in the level of the pedicle. So I choose the pedicle approach to remove the bone. The big size of the bone is about 5 millimeter diamond bone. Majority of my case, I use a 40 millimeter. This is a pedicle. Above is the spinal cord. Angled osteotomy, about 2 millimeter. This is a special bone. I can change the angle of the bone. At last, we will do the SIT test. SIT test means stop irrigation test to do the bleeding control. This method is for the difficult case designed by Dr. Sun, the transforaminal and the laminar nectomy facetectomy. For the calcified disc herniation, especially in the central part. A left case. I prefer to use the hole make by the bone to make sure the margin of the decompression. A small size bone to make a hole. Then I use the C-arm to make sure where is the margin of the decompression. Dr. Sun dislike calcium punch. He makes in the laminar and use the detector to peel off. And this is calcified disc herniation in the center area. I can detach the cervical spinal cord, but I'm afraid of detach the cervical spinal cord. It's very dangerous. But this case, I try detach the spinal cord. I use the osteotomy to detach. You can see the osteotomy to detach the spinal cord. Then I remove the calcified part. So dangerous. I designed the thoracic flat wood technique. It's similar to Dawson's cervical spare tip technique for the difficult case. But the third portal for the contralateral side decompression. You can see the spinal process fluid for decompression. Case introduction. For this case is a difficult case, maybe 5 levels, the OF. I finished the 5 levels decompression at the same time. Have click the video. Very severe. I use the thin detector to detach the OF. There's too much adhesion. Then I use this tool. It's similar to the knee arthroscopy to remove the bone. This is a special OPLL to transverse the spinal cord. So I choose a special approach. I open the dura to remove this big OPLL. You can see the transverse puncture the spinal process. So this case is a very high risk. I opened the dura. I found the bone. For this case, I think the ultrasonic is a good choice. This one. Ultrasonic bone knife. So you can see UBE, we can use every kind of tools. We can use the open surgery tools, so it's very good. There's a similar result to the open surgery. The water media and the magnified view, very safe. I use the metal protective tube to protect the nerve root. Then I insert along this tube the bone to remove the bone. But in Singapore, there is a transparent one. The tip of the UB thoracic process, the two principles. Do not touch. You choose the calcium punch. Maybe this part very thin, and use about 130 or 150 angle. Yes. This method is introduction by Dr. Sun. Dr. Sun first use the bone to mix in the bone, then use the detach to peel off the bone. So conclusion is first, the familiar anatomy, exact portal, suitable approach to principle. The book is Javier. Can you give me a book? I only have the PDF. I write the cervical part and the thoracic part. So we must have enough knowledge, and the fear is the first of the many fields. Thank you.